Have blood flowing.
Exactly. You got to have enough blood and it has to be moving. All right. Anybody tell me a function of blood?
It transports oxygen to your organs and your tissues.
Protection.
Regulation of your body temperature. Nutrients.
Good. Good. All right. That's good. Tell me in 4 words the composition of blood.
It would be plasma formed elements, which are platelets, white blood cells, red blood
How
cells.
come it's not plasma and cells?
Because platelets aren't cells.
Platelets are not cells. All right. Now, plasma is the liquid portion of blood, isn't it?
Yes.
All right. And we found that there are some very helpful things dissolved in plasma. Right? What kinds of things are dissolved in plasma circulating throughout the body?
Nutrients.
Hormones, metabolic waste, respiratory gas.
Respiratory gases. Let's don't leave those out. All right. Now, actually, plasma is mostly what?
Water.
It's mostly water.
92%.
Now, there's some important plasma proteins. What's the most abundant protein in plasma?
Albumin.
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 Albumin. Makes almost 2/3 of the protein content of blood. Give me. All right. When do we first see blood cells appearing in the body? Actually, in the embryo.
3 weeks.
3 weeks. And is the bone marrow making those red cells at that time?
No, liver and the spleen.
Yolk sac. Yolk sac may be a foreign term to you because we haven't come to that yet, but the yolk sac is one of the extraembryonic membranes that we'd be talking about down the line. But that's the earliest site of production of blood cells. The embryo actually has a functioning heart at 3 weeks and pumping blood. All right? After the yolk sac, then what organs take over to about the 5th month?
Liver and the spleen.
Liver and the spleen. And then where after that are blood cells, all formed elements made in the bone marrow, the red bone marrow. All right? That's good. What's the technical term for red blood cells? All right. Remember I told you I wanted you to know the normal red blood cell counts for males and females and adults. Now, ways of measuring adequacy of red blood cells. One is a procedure that Early Lab did tonight. What did you do, Early Lab?
Tiny red blood cells.
Huh?
Tiny red blood cells.
Total red blood cell count. All right. Another way of assessing whether there's enough blood or red blood cells is something called hematocrit. And in a subsequent lab, you're going to be doing hematocrit. So we won't explain that now, but we will in lab, and you'll be actually doing those. All right. Now, are red blood cells have any particular kind of shape?
Yes, they're biconcave.
Biconcave disc. All right. And what's the average diameter of a normal red cell?
7 point.
Between 7 and 8 microns. Very small, right? Now, can red blood cells get into tiny capillaries that are smaller than their diameter?
Yes.
Yes, they can.
Because that shape they can fill.
Now, so what is it in blood that transports the respiratory gases? Well, let me put it this way. What in blood transports oxygen?
Hemoglobin.
I know, what cell? Red blood cells. Right. Now, what is it about the red blood cells, inside red blood cells, that actually transports the oxygen?
The hemoglobin.
Hemoglobin. Hemoglobin is a complex protein, isn't it? All right, so you've got a globular protein with heme units, and to each heme unit is bound a particular ion.
Iron.
Iron. and it's to the iron that the oxygen atoms actually bind. All right? That's good. You'll need to know the normal hemoglobin levels for adults. You can refer to your notes for that. All right. What is the umbrella term for the formation of all blood cells?
Hemocytoblast? No.
It's
Uri-
a tricky word.
poiesis.
Hematopoiesis. All right. What is the word for production of red blood cells? Erythropoiesis. The eryth means red, so those are red blood cells. All right. Now, there is a certain hormone that stimulates red blood cell production. What's the name of that hormone? Erythropoietin. And where does that come from? The kidneys. All right. Now, normally there is a low level of erythropoietin being secreted all the time to stimulate red blood cell production, because our old and damaged red blood cells are constantly being taken out of circulation by the spleen. So we've got to replace them from the red bone marrow. All right? Now, there is a condition that causes the kidneys to release higher than normal amounts of erythropoietin. Hypoxia. Now, what is hypoxia?
High oxygen.
Low oxygen. Low oxygen. Okay? The HYP means low. Okay? So a hypodermic needle is one you put under the dermis of the skin. All right? So hypo means lower than normal. All right? So hypoxic conditions, renal hypoxia, causes a release of an increased amount of erythropoietin, which increases the rate of red cell production. All right? Now, there are different things that can cause renal hypoxia. Right? You can be in a situation where the oxygen content of the air is lower than normal, right? You could be in a situation where you're in hemorrhagic shock and you've got a low blood pressure and a low flow rate. So if you've got a low flow rate to the kidneys are not getting as much oxygen as they normally would, right? If something is wrong with the lungs so that you can't take on oxygen from the atmosphere, that can also produce the same problem, can it? All right. Okay, so we got down, I think, to, we were at this thing about regulation of erythropoiesis, where's that thing here? Oh, here it is. A little quicker. Now, one of the things that will cause an increased rate of erythropoietin is anemia, which means anemia, the definition of anemia is a lower than normal number of red blood cells and or hemoglobin, which actually can produce hypoxia, right? Because oxygen is carried by hemoglobin on red cells. So if you're anemic, then you're going to have a lower than normal oxygen carrying capacity of the blood. This is just a simple diagram that shows you how erythropoiesis is regulated. So if we got hypoxia of from any cause. Kidney produces more erythropoietin, stimulates the red bone marrow, we produce more red cells, and we're back to in homeostatic balance. Because when this happens, when we get sufficient oxygen carrying capacity of the blood, the kidney then will reduce its release of erythropoietin. I'm thinking let me check back here. I'm thinking we missed something here. No, I guess we haven't come to it yet. Let me skip. Yeah, that's what I'm not there yet. Okay. So, speaking of anemia, what you see at the top of the slide there is the definition of anemia that I just gave you. All right, so it's a reduction in hematocrit, which is a measure of red blood cells, total number, or reduction in hemoglobin, or both, Now, notice this. Anemia is an indication of some disorder, not a disease itself. Okay? Anemia is not a disease. It's an indication of an abnormality. Okay? And there are a number of different things that can cause anemia. What are the symptoms and signs of anemia anyway?
Being
And before you
tired.
answer that, let me ask you, what's the difference between a symptom and a sign?
Symptom is something that you feel, sign is something that I can see.
Exactly. Did you all hear that? A symptom is something a person feels or can describe. A sign is something you can physically observe, all right, on examination. All right, that's the difference. So what are some symptoms of anemia?
Fatigue.
Fatigue, feeling cold, get out of breath easily, don't have a lot of energy. What? Somebody say? Is that a symptom or a sign? That's a sign. Okay, so give me some signs of anemia.
Dark
Loss of
spots.
color, you mean what?
Pale, looking
Pale. You get pale.
Dark spots
All right.
under the eyes.
Hmm?
Dark spots under the eyes.
Not that I'm
No.
aware of. No.
You can get diaphoretic, right?
You can, yeah, because you can get hypotensive and diaphoretic from that. But so you can have a pallor of the skin. What about dark-skinned people? You can't see pallor in their skin. Where do you look?
Under the eyes.
Yeah, you can pull the eyelid down and observe the conjunctiva. It'll be pale. But you can also look in the mouth. Look at the mucous membranes. They'll be pale, not the flush pink that you usually see. All right. The nail beds will be pale. And when you press on the nail bed, you press the blood out, the color doesn't come back fast like it does in a person with a normal red blood cell count. All right. Now, some common causes of anemia. Obviously, you can have an insufficient number of red blood cells. That's part of the definition, isn't it? Mm-hmm. Now, how does this happen? Well, you can lose blood. Obviously, that's a cause, isn't it? That's hemorrhagic anemia. You can have something going on that's accelerating the destruction of red blood cells, breaking them down, breaking them apart. In other words, hemolyzing them. That's a hemolytic anemia. Or you can have a decreased production of red blood cells. In other words, something is going on in the bone marrow that's crowding out the precursor cells. And you have what's called an aplastic anemia. Okay? A in front of a word means without, right? Now what's the plastic mean? How'd that get in there? Why do plastic surgeons call themselves plastic surgeons? Do they use a lot of plastic? They don't use any, actually, that I'm aware of. Plast, P-L-A-S-T, comes from the Greek meaning to make or form or construct. All right? So, you're not able to form the red blood cells in adequate numbers. So you have an aplastic anemia. All right, you could have a low hemoglobin content. Isn't that part of the definition? Exactly. All right, so that can be from nutritional deficiencies. We already know that there are certain special things that red blood cells need, like iron and vitamin B12. So that could be a problem. But you can also have an abnormal hemoglobin molecular structure. So, here's just a couple of examples. There is a class of hemoglobin abnormalities called thalassemias, and a major and minor, and they are more prevalent in the Mediterranean area. You can have sickle cell anemia. You've heard of that, I'm sure. What's the problem in sickle cell anemia? One little amino acid in one chain of the molecule is defective. That one abnormality can cause tremendous grief and morbidity, and even mortality. All right. Now, so if anemia is this, what's polycythemia?
The opposite.
What does poly mean? Many. Many. So, too many red blood cells. It's the opposite of anemia. So, you can have natural causes, primary or secondary. You can have some disease that's causing it. But, you can also have an artificial polycythemia. Have you heard of blood doping?
Yeah.
Well, I'll tell you what it is. And this comes up every year, it seems, around the Tour de France, the bicycle race in Europe. What happens is, and it's not just bikers, anybody can do this, but what blood doping basically is the banking of one's own blood to be given back to that person at a subsequent time. So here's how it works. An athlete who wants to have accelerated performance will have some blood taken from him or her and banked. All right, the loss of that blood stimulates the bone marrow to make more blood cells. And so the blood count comes back up to normal. In several weeks, this person may have another unit of blood drawn and banked, and blood count comes back up to normal. This is all before the event, you see. And so as the event is coming around, this person has his or her own blood transfused back into him or her. And what is the expected result from that?
More
You'll
oxygen.
have more oxygen carrying capacity in the blood, right? Because your hematocrit and hemoglobin are going up. So it's considered illegal in bicycle racing circles at least, if not immoral. But anyway, that's what blood doping is. It's not without unpleasant circumstances too, because when you do this, when you really significantly increase the number of blood cells, it's possible to get sludging of the blood in very tiny blood vessels, and you can have some problems from that. But anyway, that's what blood doping is. All right, now, remember our blood cells are constantly being produced in the bone marrow, right? And they're continuously being taken out of circulation, primarily by the spleen, correct? All right. Now, when those blood cells are taken out of circulation, do we just throw the whole kit and caboodle away? Or do we save some stuff that's in those red cells for use with making other cells or even other red cells? or the latter. All right? So let's look at how it goes. All right, so we know that low levels of oxygen will stimulate red blood cell production. All right, and so our blood levels rise. Now we need some raw materials to make those blood cells, the nutrients that all cells need, plus some special things that red cells need, like iron and vitamin B12 and folic acid and so forth. And so we have new red blood cells entering the bloodstream constantly. Now it says here that they function about 120 days. You mean to tell me that's as long as a red cell will last? About 120 days, 4 months? That's true. But why is that now? Why don't red cells last longer than that?
No nucleus.
Because they lost their nucleus when they came out of the bone marrow. All right? So our old and or damaged red cells are going to be taken out of circulation by the spleen. The liver helps too, and maybe the bone marrow. Now, we're not going to throw away everything. This hemoglobin, when it breaks down, remember, hemoglobin is a complex protein, isn't it? Do we want to throw away all those amino acids? No. So we're going to save the protein part of the molecule, the globin, which is made up of many amino acids. So we'll save those. This heme, remember the heme to which the iron is attached? All right, that heme is going to give up its iron, but we're not throwing that away either. We're going to store it. We can store it in places like the liver. Remember, though, we don't store it as free iron because free iron is toxic. So it has to be bound to a protein, right? So we're going to store it as either ferritin or hemosiderin. The rest of the heme molecule, the liver breaks down and it becomes a part of bile. The liver makes bile. All right. Bilirubin is a component of bile.
Okay.
All right. In fact, that's what makes bile green, the bilirubin.
Yeah.
All right. And so this bilirubin then passes out with the bile salts and everything else that makes up the bile into the intestinal tract. Mixes with the food that we eat, helps us, there's the things in that bile that helps us digest our food, especially our fats. And in fact, it's the bilirubin that gives stool its normal brownish color. And some of that bilirubin is reabsorbed into the bloodstream and is what makes our urine a typical faint yellow color. It's a diluted form of bilirubin. So that's why urine is yellowish. When you're dehydrated, your urine is more yellow, and when you're overhydrated, it's almost like water sometimes. All right. So anyway, that's what's happening right there. Meantime, from our food that we've ingested, our food nutrients, we're getting the nutrients to use to make more red cells. So we combine those nutrients with our stored iron, which is sent to the bone marrow, and we make new red cells on a continuous basis. All right, let's talk about blood types. Do you know your blood type? What's your blood type? AB negative. All right. Anybody else?
Say positive.
Huh?
Say positive,
O
maybe?
positive, O negative. All right. So you're what?
I'm AB negative.
AB negative. Oh, I just said A negative. AB negative. That's the least common blood type. All right. So if a person is, say, A positive, what does that actually mean?
They can only take A positive blood.
No, what's it mean? It means,
Unless you have antigen,
yeah, I'm going to show you in a minute. It means your blood type is A. But what's the positive or negative mean?
factor.
Yes, it's an indication of the presence or absence of the Rh protein on blood cells. All right. So whatever your blood type is, it's going to be a positive or a negative with them. So when you give a blood type, it always has to be the letter and then a positive or a negative. Now, in talking about blood types, we have to talk about antigens and antibodies. Antigens are so-called foreign substances. Most of the antigens that hurt us are foreign antigens. But we do have some self-antigens of various types. And on certain people's blood cells, they have certain self-antigens that belong there. All right? Now, antibodies are proteins that are produced by our immune cells to act against foreign antigens that get into our bodies. So we have an antigen-antibody reaction when we have a foreign antigen enter. All right. I'm simplifying this because we will be talking about immunity a little later on. Now, you will also see this word and this word. Antigens are also called agglutinogens. Antibodies are also called agglutinins. So remember that these are the same thing and these are the same thing. Antigen actually is a compound word. It's a made-up word, actually. Antigen. What it means is antibody generating. In other words, the presence of foreign antigens produce, results from antibodies acting against them. All right, now we have many kinds of red blood cell surface antigens. There are at least 30 common ones in humans. But there are 3 types that we are going to concentrate on because these are by far the dominant ones. A and B. Okay, so 3 types of surface antigens for the blood type A and B, and then the Rh antigen. All right. Now, the red blood cells of a person can have either A or B surface antigens. If a person's blood has surface antigen A on his or her blood cells, they are blood type A. If a person has surface antigen B on his or her blood cells, they are blood type B. When we talk about these letters, we're talking about what's called the ABO blood type. All right, so if a person has both,
Oh no.
where did that come from? Yes, thank you. All right, so if a person's blood cells have both A and B surface antigens, the normal self-antigens, then that person is type AB blood. I'll get to the Rh later. If a person's red blood cells have no surface antigens at all, not A, not B, that person is type O blood. You with me so far? Where do you get your blood type anyway? Does it just happen? You get it from your parents, don't you? Exactly. So, if we got blood type A, we got blood type A, we got surface antigen A only, but now we've got to talk about antibodies. Because people with type A surface antigen are going to have in their plasma anti-B antibodies. You obviously couldn't have anti-A antibodies because you'd be clumping your red cells, right? But what if this person here, blood type A, was given type B blood? Not necessarily kill him, but it'd be a very unpleasant experience. And it can cause death. It can. All right, let's go to blood type B. Surface antigen B, but now this type of blood has anti-A antibodies. All right. Blood type AB, of course, has both A and B surface antigens, and of course neither anti-A nor anti-B antibodies. This is why type AB is referred to as the universal recipient. Okay. Theoretically, you could give a person with type AB blood any of these types of blood, and it would be okay. But remember, there are other surface antigens besides A and B, you know, but these are the main ones. All right, now, what about blood type O? No surface antigens at all, but blood type O has both anti-A and anti-B antibodies. That's why this type is called the universal donor. So if you have somebody come in the emergency room and profound hemorrhagic shock, and you've given them fluids and plasma expanders, and you need to give them blood now, and you don't have it, you can, in a stressful emergency situation like that, give them type O blood. Hopefully O negative blood, as we'll get to in a moment. Okay, so that's why type O is called a universal donor. Now, you got to remember though that type O blood has both anti-A and anti-B antibodies. So can you give a type O person type A blood, or type B blood, or type AB blood? No, because these antibodies are going to act against those surface antigens and going to clump the blood. All right, so here's a chart that lays out what we've been talking about. So this is a table in your text. You can look at that there too if you want, but this basically lays out where the surface antigens and the antibodies are. Now, the most, you know, in the United States, the most common blood type is O. The least common is AB. Second most common is A, and in between here is B, about 10%. I'm B positive. All right, now let's talk about Rh antigen. It's also known as Rh factor. There are many Rh factors, but 3 of them are common, C, D, and E, and mainly D. If a person has the Rh antigen on his or her blood cells, they are said to be Rh positive. If they don't, they're Rh negative. So as I mentioned earlier, we always report, you know, a blood type as the letter and then a positive or a negative. Now, Rh surface antigens occur naturally. What do we mean by that? You got it from your parents. You got, whether you're Rh positive or Rh negative, you got it from your parents. All right. But remember, anti-Rh antibodies do not occur naturally in the blood. Okay, so a person who's Rh positive is not going to have anti-Rh antibodies present. That wouldn't be good, would it? No, that makes sense. But, so they don't occur naturally. But you can develop antibodies to Rh. And people do. And the development of antibodies to the Rh surface antigen occurs only after exposure to the Rh surface antigen. Remember, we got antigen-antibody reaction. In other words, in order for a person to develop antibodies against Rh, we're going to have to be talking about an Rh negative person who is exposed to Rh positive blood, right? Right. The wrong transfusion. Not a lot of them, but the wrong one. Are you with me so far? It gets a little confusing, doesn't it? So let me give you some examples. Let's say that we have a woman who is pregnant with her first baby. She's Rh negative. Now let's just say that medical knowledge has not advanced so far yet as to know how to handle this, but let's say she's pregnant with her first baby. She's Rh negative. We know that. All right. Now, we can know what the baby is. We can know in the mommy's womb whether that baby is Rh negative or Rh positive. Did you know that? How is it so simple to know?
Because it's from the parents.
Because if the father is Rh positive, the baby's going to be Rh positive. Because this is a dominant trait. Positive always dominates over negative for Rh. So if the father is positive, the offspring's going to be positive, even though mother's negative. All right, so now, does the blood of the mother and the blood of the fetus mix during gestation? No. No. But at delivery, when the placenta separates, it's possible for some of the fetus's red blood cells to be introduced into mother's circulatory system. You follow me? That tearing apart of the placenta, you can have some of the baby's blood cells enter the mother's bloodstream. Now the mother has Rh positive blood cells circulating in her blood. Her immune system is going to develop antibodies against Rh. Now, is the first baby going to be affected by any of this? No. But let's say that this same mother then gets pregnant again. We know the baby's going to be Rh positive. Mother's Rh negative. Now, she's got anti-Rh antibodies circulating in her bloodstream. Now, I told you that the blood streams of the fetus and the mother do not mix. But certain things, like certain antibodies, can cross the placental barrier. So now, mother's anti-Rh antibodies can cross the placental barrier and start to destroy the fetus's blood cells. Are you with me? All right. So this can damage and sometimes kill the offspring, the baby in the womb. You with me? So this is an example of how this works. In other words, the mother was exposed to Rh antigen, developed antibodies against it, and now they can act against subsequent offspring. Of course, there's a way to handle this now. If this is known ahead of time, then you can give a commercially prepared anti-Rh serum, like Rogan, to the mother in the 3rd trimester, during delivery, and postpartum, to kill those potentially damaging anti-Rh antibodies. Okay, you with me so far?
How far along?
Now let me give you another example.
Professor, how far along? would it take before the antibodies could affect the fetus?
I don't know the exact time sequence, but I do know that it absolutely will happen. It has to happen. It will happen. You can sometimes, have, the condition is called hemolytic disease of the newborn, or the fancy term is erythroblastosis fetalis. But what's happening is those anti-RH antibodies are attacking the red cells of the fetus in the womb and creating a profound anemia in the fetus. And it may be so profound that the fetus will not survive. Sometimes they can survive, and when they're born they can be transfused. But the thing to know is ahead of time whether it could happen and take the necessary steps to keep it from happening. Let's take a somewhat simpler, maybe, I don't know if it's any simpler, but let's see. Well, that's my first example here. Let's say a person needs a blood transfusion. Let's say a person needs a blood transfusion. And they are RH negative, but they receive the right blood type, the letter type, but RH positive blood. It's the same scenario, isn't it? Because now this transfused blood has the RH antigen on its cells, red cell surfaces. Now this recipient is exposed to this as a foreign antigen, develops antibodies against it. Now, is this going to hurt the recipient of the transfusion the first time it happens? No, because it takes a while for the antibody titer to be built up. But let's just say, God forbid, that down the line this person received another blood transfusion, again of RH positive blood. Now what's going to happen? There's going to be a transfusion reaction, isn't it? Because the recipient's anti-RH antibodies are going to agglutinate or try to clump these transfused wrong blood cells.
Would it happen really fast, like before all the, like whoever's transfused?
Yeah, it will happen during the transfusion. That's what can cause a transfusion reaction, for example. You'll know it during the transfusion. So that's RH. So the point is that anti-RH antibodies do not occur naturally in the blood of RH negative people. The RH negative people have to be exposed to the antigen first, and then you can have problems later on. The first exposure is not a problem because no antibodies are built up. It takes a while to build up an antibody titer. It doesn't happen instantaneously. Now here's a question. Can blood be safely transfused across racial and ethnic lines?
Yes.
Absolutely. It happens all the time. All right. Now, blood typing and cross-matching. So, when you donate your blood at the blood bank, they're going to type it. They're going to give you a type, whatever a type, the ABO type and the presence or absence of the RH antigen. All right? You're going to bank this blood. So there's a person in the hospital that needs a blood transfusion. They call the blood bank, we need some A positive blood. Well, they're not going to just ship that right over and hook them up right away. They're going to do some further testing on it. First of all, they're going to test the recipient, make sure we got the right type here, match it to the right type in the blood bank. But remember, we said that there are other surface antigens besides just A and B. So what we now go to do is cross-match. In other words, we're looking for a reaction with other than A and B surface antigens. because we want to get as close as we can with this. So this process here is done whereby you mix the donor's red cells with the recipient's serum, and you mix the recipient's red cells with the donor's serum, back and forth like that. If there's no evidence of a problem, agglutination, a reaction, then this blood is cleared for transfusion. All right? But in spite of that, sometimes transfusion reactions do occur, don't they? They hopefully are rare, and will be rare, but they do occur. Now, what is a clinical picture of someone who's having a transfusion reaction? They could break out in hives, they could develop a fever, an accelerated heart rate, pressure might drop some, might have pain, okay? Nausea, vomiting. Okay, so those are relatively, I almost say minor, I put that in quotation marks because no transfusion reaction is minor. So usually they're not life-threatening, but they can be. They can be because it's possible to get a massive hemolysis rather than just an agglutination and clumping. You get massive hemolysis, and a really severe reaction. But I ask you, what is the main cause of transfusion reactions? Do you know? What?
Too many transfusion?
I didn't hear you.
Too many transfusion?
No. No.
Just human error.
Do you hear that? Clinical error. Hanging the wrong blood. Can you believe it? It happens. The patient has got an identifying marker. It's clearly marked on the blood what it is and whose it should be for. But this does happen. Clinical error.
Doctor, can I
It
ask a
shouldn't
question? I have a family member who has a lot of transfusion. He has diabetes and kidney failure, and he's just congestive heart failure. I mean, he's just a mess. So he gets a lot of transfusions. So it takes a really long time for this process to occur once they say, okay, you need to get some more blood. Is that because, I know they do the blood typing, and then they're waiting for the blood to come from the blood bank, and then that's when they do the cross-matching, is once that donor blood arrives to the hospital or wherever he's at? Okay, so then that takes time for them to do this cross-matching with the donor blood and his blood, and then finally they get it done. Because it does take, a few hours by the time
Yeah, it takes a while.
Yeah, and so I guess this whole procedure just takes time for it to get into place.
Talk about donating blood. Has anybody ever donated blood? I think I've donated blood in the past, but when you donate the blood, it's free, isn't it? You're not charging for that, are you? In fact, they're going to give you a T-shirt or something for doing it, aren't they? But if you receive, say, you gave a unit of blood. If somebody gets your unit of blood in a hospital, is it going to be free then? No way.
What if it's
They're going
family
to charge an
member?
arm and a leg for that.
What if it's family
That's what
member?
bothers me. People give up their blood freely without charge, and they charge them exorbitantly in the hospital. Of course, everything that you get in the hospital is exorbitantly priced.
What if it's family member to family member? Let's say we're cousins and she needs my blood. We're the same type. I mean, I can see charging for the service, but is it still the same price? Even if I say, yes, she can have my blood?
Yeah.
Really?
Yeah. Now, I think I've been told that if you are a blood donor, you'll get some consideration as to the charge.
Okay.
But I'm not sure about that.
Okay.
Well, yeah, there is such a thing as autologous transfusion. Sometimes for elective procedures, when you know there's going to be some blood loss, you'll have the patient go to the blood bank and give his or her own blood ahead of time and bank it.
Right.
So we don't have to worry, other than for clinical error, getting the wrong blood. In other words, this person is going to get his or her own blood back specifically. All right? But that ain't free either.
No, it's a luxury.
Which I can see the
I know you're
service
paying for
fee.
the service, but
Yeah.
So, if you have, I've been told if you have tattoos, you can't give blood.
Only for a year.
Oh, so you have to 12 months after pass.
Yeah,
Okay.
because of the needles.
well, if that's the case, 90% of you in here can't give blood, right?
I mean, I can
After
give
a
it.
year you can.
After a year?
Yeah.
Okay. All right. Some people can charge for things they give, you know, like there are certain clinics where they want serum,
Mhm.
they'll pay you for,
Paid for police.
they'll pay you for. All right, now, here is blood typing. You're actually going to be doing this in the lab later, but you're going to be looking at something like this in the lab. So let's say that we had, what we do is we put 2 drops of blood on a slide. We have a bottle of anti-A serum here and a bottle of anti-B serum here. So we've got 2 drops of blood. We put a drop of anti-A here, a drop of anti-B here. If we get clumping on both sides, it's type AB, right? And so if it's B, it's going to clump the B side. If it's A, it's going to clump the A side. If it's O, it's not going to clump either side. All right. Now, one thing that gets you confused on this, and I'll mention it in lab when we come to it, is you see something like this. You say, okay, I've got my 2 drops of blood, I got anti-B, so I'm type A. No. Look, this is anti-B serum up here. If anti-B reacts with anything here, it's going to be the B surface antigen, isn't it? So it's going to be type B. So that's one way you can get confused when you're typing blood.
Okay.
All right, that brings us to white blood cells. The technical term is leukocytes. Now, we already know that we have approximately as many white cells as we do red cells, even though when we look at a blood smear, it doesn't look like that. That's because most of the white blood cells are in tissues other than blood. The normal white blood cell count is somewhere in the range of 5,000 to 11,000 white blood cells per cubic millimeter of whole blood. Again, the numbers may vary a little bit. Sometimes you'll see 4,000 to 11 or something like that, but it's basically in this neighborhood right here. We have 2 main types of white cells, granulocytes and agranulocytes, as I mentioned in Lab 1. The folks who were not here for Lab 1, look on the back of the handout sheet for Lab 1. If I haven't given you that already, I will. Now, where do these white blood cells come from? The same place red blood cells come from. The same place the megakaryocytes come from that produce the platelets. The common precursor cell, the common stem cell, the hemocytoplasm. They all come from red bone marrow, but as we're going to find later, certain of those white cells will have some more work done with them in a gland called the thymus, which is located right here. We'll get to that later. Remember, we have 2 stem cell lines, the myeloid and the lymphoid, right here. This is the myeloid line on the left, right here, and this is the lymphoid line. So which one white blood cell comes through the lymphoid line? Lymphocyte. All right. Now we have some more terms. And by the way, you should know the normal white blood cell count. 5,000 to 11,000 cubic millimeters. Here are some terms. Overproduction of white blood cells, in other words, production of a lot of them, more than we normally have, is called leukocytosis. Now let me tell you how this word is made up. The leuc stands for white. The CYT refers to cell. Anytime you see osis at the end of a word, it means full of or abundance of. All right? Underproduction of white cells is called leukopenia. The leuc stands for white, the O is a connecting vowel. Penia means a deficiency of. Anytime you see penia, it means a deficiency of something. Now, here is an alternate term, leukemias. Now, leukemias are characterized by high numbers of white blood cells, right? So why don't we call that a leukocytosis? Well, technically it is a leukocytosis, but this is a special thing. This is a special type of excessive numbers of white cells. This is due to a malignancy. And besides that, the white cells that are being produced are not normal. All right? So somebody who has a bacterial infection, has an abscess somewhere, they're going to have an elevated white blood cell count. That would be a case of leukocytosis. All right. Some characteristics of white blood cells. They move like amoeba do, if you've had biology. Diapedesis means their ability to squeeze through the intercellular clefts of blood cells and get out into the tissues where the problem is. Chemotaxis refers to their being drawn to the site where they're needed by chemicals that are present at the site of injury. Phagocytosis means the capacity of certain white cells to ingest foreign things like bacteria, to take them into their cytoplasm and break them down and kill them. That's what phagocytosis is. All right, let's go through the 5 types of white cells. This should be actually more of a review at this point. These are the 5 types. Neutrophils, eosinophil, basophil, lymphocyte, monocyte. All right, let's go through them one at a time. Neutrophils, as we said before, are the most numerous white blood cells in a normal blood sample. They make up about 50 to 70% of the white cells. They are highly mobile. They're usually at the first to appear at the site of injury, particularly if there's a bacterial infection, because they really love to go after bacteria. So they're highly phagocytic. Highly phagocytic. They do, however, have a short lifespan, on a matter of just a few days or hours. And when they're actively engaged in phagocytosis of bacteria, their lifespan is on the order of seconds or minutes. Because as they ingest these things, they're being killed themselves sometimes. Eosinophils. They make up about 2 to 4% of white blood cells in a normal sample. They have a characteristic appearance, as you know, with white stain. Their most important role is going after parasitic worms. Now, if you've studied parasitic worms, you know that some of them are huge, long, okay, tapeworms and things like that. And these little bitty white blood cells, how can they possibly ingest a big tapeworm? They can't. They release toxic substances that kill them. They are also active in allergic reactions. So in allergic reactions, their numbers tend to increase. Basophil. the least common white blood cell in a normal blood sample. Less than 1% of them will be basophils. But they are important in the inflammatory response because of some substances that they contain in their cytoplasm, namely histamine, which is a vasodilator, and heparin, which is an anticoagulant. Now, how that works, we will talk about when we get to immunity and inflammatory response. Monocytes, the largest of the white cells, they make up about 3 to 8% of the white blood cells in a normal blood sample. They are the largest white cell. These are the cells that become the macrophages. We'll be talking a lot about macrophages. Macrophages are highly phagocytic cells, and they are present in many organs. They're ubiquitous and extremely important in the inflammatory response, and they even have an important role in the immune response too, which we will get to. The lymphocyte, the smallest of the cells, but the second most common in number. They make up about 25 to 40% of all the white cells in a normal sample. These are the main cells of the immune response, the lymphocytes. Now, those macrophages are important, but the lymphocytes are the key cells of the immune response. I told you earlier that some of those white cells, that all white cells begin in the red bone marrow, but some of them have to go through the thymus for some educational reasons that we'll talk about later, and the ones that do are lymphocytes. Certain types of lymphocytes have to have some more work done with them in the thymus that we'll talk about later. There are 3 classes of lymphocytes. There are some called T lymphocytes, some called B lymphocytes, and some called NK lymphocytes. The T stands for thymus-derived. Remember, they all form in the red bone marrow. But the T cells, the thymus-derived ones, that's what the T is for, thymus, they're the ones that have to pass through the thymus for a selection out process to be sure we don't retain any of these lymphocytes that could be injurious to us. The ones that don't pass the test in the thymus are done away with, and we're left with the ones that will be helpful to us individually. The B cells, B stands for bone marrow. These are the ones that do actually mature in the red bone marrow, and the B cells are the ones that ultimately will cause production of the antibodies. Now, the B cells themselves are not the ones that produce the antibodies. There's an intermediate cell called the plasma cell, but plasma cells come from B cells. So we'll talk about all that later. All right. Natural killer cells are a more general type of body defense cell. So they're not really part of the specific immune response. They have a more general role of surveillance in the body for abnormal cells, which they will attack. So the NK stands for natural killer. Now, on our slides in the lab here, when we're looking at white blood cells, are we able to tell whether we're looking at a T cell or a B cell or a natural killer cell with these scopes? No. All we can do is tell what type of blood cell we're looking at. We can tell if it's a lymphocyte, but we can't tell any more than that, because you need special diagnostic techniques to determine whether it's a T or a B, and this is commonly done. It's commonly done. So you can do it with immunofluorescence, you can do it with electron microscopy. It's all computerized techniques, but there's no way we can tell any more on our scopes than whether it's just a lymphocyte. The lymphocytes have the longest lifespan of all the white cells. This makes sense because they're involved in the immune response, right? So when you develop an immune reaction to something, or if you're immunized against something, that immunity is going to last a long time, isn't it?